Okay, let's unpack this. Imagine you're in a high-stakes situation where every second counts, and understanding two similar-sounding but profoundly different medical emergencies could be the key. That's exactly where we're going today.
Yeah, it's a critical distinction.
This deep dive focuses on diabetic ketoacidosis, DKA, and hyperglycemic hyperosmolar syndrome, HHS, two acute, really life-threatening complications of diabetes.
Absolutely serious conditions.
Our mission for you, as we kind of distill insights from expert clinical notes on emergency medicine essentials, is to help you walk away well-informed, not just on their definitions, but how they differ, their causes, and the crucial steps in management.
We're basically giving you a shortcut to understanding these complex conditions.
Exactly. And even if you're not an emergency clinician, grasping these distinctions provides a clearer picture of diabetes management and, well, emergency response in general.
It really does. It shows how the body works or sometimes doesn't work.
So let's set the stage. Understanding these is critical for clinicians, obviously, but also for anyone curious about how the body handles extreme glucose imbalances. Let's start with DKA.
Okay, DKA. It's an acute, major, life-threatening complication. The key characteristics are hyperglycemia, so high blood sugar ketoacidosis, meaning the blood becomes acidic, and ketonuria, which is ketones in the urine.
And who typically gets this?
It's primarily seen in people with type 1 diabetes, but it can occur in type 2 under conditions of severe stress or a really significant lack of insulin.
And the why behind it?
Well, basically, the body just can't use glucose for energy because there's an absolute or very severe relative lack of insulin, so it's forced to break down fats for fuel instead.
And that breakdown produces?
Exactly. It produces these acidic byproducts called ketones. That's what leads to the acidosis.
Okay, that makes sense for DKA. Now, let's transition to HHS. You mentioned it's also a severe complication, often in type 2 diabetes, but with a crucial difference, right?
That's right. HHS involves extremely high blood sugar levels, often, much higher than in DKA. But the key thing is without significant ketosis or acidosis.
So no major acid buildup?
Generally, no, or very minimal. The main issues in HHS are profound dehydration and hyperosmolarity, meaning the blood gets really concentrated. This all stems from that sustained super high hyperglycemia, which leads to what's called osmotic diuresis, basically peeing out lots of water.
And why don't the ketones build up like in DKA?
It comes down to insulin again. In HHS, insulin levels are too low to prevent the high blood sugar, but they're usually just high enough to suppress that massive fat breakdown, lipolysis, and therefore prevent major ketone production. That's the fundamental distinction.
Gotcha. So different paths to crisis. Here's where it gets really interesting, I think. Both DKA and HHS start with that insulin deficiency and high blood sugar, but their internal mechanisms, they really diverge, leading to these very different clinical pictures.
Exactly. The shared starting point is that lack of insulin effect. This means glucose can't get into the peripheral tissues, like muscle, so it builds up in the blood hyperglycemia. The cells are essentially starving, even with all that sugar around.
And the body reacts to that starvation.
Oh, yeah. It releases counter-regulatory hormones, things like glucagon, growth hormone, cortisol, catecholamines. These basically shout panic to the liver.
Telling it to do what?
Telling the liver to make even more glucose through processes called gluconeogenesis and glycogenolysis. So it just amplifies the high blood sugar even further. It's a vicious cycle.
And all that glucose floating around. You mentioned osmotic diuresis. That leads to dehydration, right?
Absolutely. High glucose increases the osmotic gradient, pulling water out of the cells into the bloodstream. Then, when the glucose level overwhelms the kidney's ability to reabsorb it, which happens pretty quickly, it spills into the urine.
And takes water with it.
Exactly. Glucose takes water and electrolytes with it. That's glycosuria. This causes significant dehydration. And here's a key differentiator. The dehydration is typically much, much more severe in HHS.
Making the risk higher for things like
cardiovascular collapse. The sheer volume loss can be immense in HHS.
Okay, so dehydration is huge, especially in HHS. But let's circle back to that crucial distinguishing feature. The presence or absence of significant ketonemia and acidemia. Tell us more about DKA's ketone situation.
Right. In DKA, the absolute or very severe relative lack of insulin means there's nothing really stopping lipolysis, that fat breakdown. So you get increased release of free fatty acids from fat stores.
And the liver converts these.
Yes. The liver takes these fatty acids and, through a process called beta oxidation, converts them into acidic ketone bodies, acetone, acetoacetate, and beta-hydroxybutyric acid.
And these just build up.
They build up rapidly. This leads directly to ketonemia, ketones in the blood, and metabolic acidemia, making the blood acidic. The body tries to buffer this, mainly using bicarbonate, so you see low serum bicarbonate levels as the kidneys try to compensate. Now contrast that with HHS. Here, you see minimal ketone body production.
Because there's still some insulin action.
Precisely. It's a relative insulin efficiency. There's usually just enough insulin around to inhibit or at least significantly limit that large-scale lipolysis and subsequent ketogenesis. The insulin-to-glucagon ratio is higher in HHS than in DKA.
So minimal ketones, minimal acid buildup.
Correct. Minimal or no ketone bodies means minimal or maybe just mild acidemia.
Okay, let me try and summarize this. So what does this all mean? DKA is largely about the acidic ketones, resulting from the body burning fat because it can't use glucose. HHS, on the other hand, is more about extreme dehydration and that hyperosmolarity, that super concentrated blood, because there's just enough insulin to stop the major ketone production, but not enough to control the sugar.
That's a really good summary. Two very different crises stemming from the same root problem. Insulin issues.
Now, for the clinician, or even just for us understanding this, recognizing the specific markers is, well, it's crucial for rapid diagnosis. Let's look at how DKA is distinguished first.
Okay, diagnosing DKA. We look for a specific triad, really. First, hyperglycemia. Blood glucose is generally over, say, 14 millimoles per liter or 250 milligrams per deciliter.
Okay, high sugar.
Second, ketoacidosis. This means evidence of metabolic acidosis, a blood pH less than 7.35, and a serum bicarbonate level less than 18 millimoles per liter.
Acidic blood, low buffer.
Right, and often an elevated anion gap, which points towards those unmeasured acids, like the ketones. And third, of course, is the presence of ketones themselves, either in the urine, which you can check with a simple dipstick, or measured directly in the serum, usually as beta-hydroxybutyrate.
And clinically, how does the patient seem?
Well, DKA tends to develop relatively quickly, hours to maybe a few days. Patients often present with symptoms like polyuria, that's frequent urination, polydipsia, which is excessive thirst, sometimes nausea, vomiting, abdominal pain, and classically, Kussmaul respirations, that deep, labored breathing as the body tries to blow off CO2 to counteract the acid. Maybe altered mental status, too.
That paints a clear, if pretty scary picture. And what about HHS? How do we spot that in the clinic, especially given those differences?
HHS tends to develop more slowly, often over days to weeks, which can make it insidious. The hyperglycemia is typically much higher than in DKA, usually over 30 millimoles per liter or 600 milligrams per deciliter. Sometimes it's extraordinarily high.
Wow, significantly higher.
Yeah. And critically, you find minimal acidosis or ketonuria. So the pH is usually above 7.3 and bicarbonate is above 18. Ketones are absent or maybe just mildly present.
So the defining feature isn't the acid, it's the...
It's the hyperosmolarity. The effective serum osmolality is typically very high, usually greater than 320 milliosmoles per kilogram. We actually calculate this using a formula based on sodium and glucose levels.
And how do these patients typically present?
Because of the profound dehydration and hyperosmolarity affecting the brain, patients with HHS often present with more pronounced neurological changes. This can range from confusion to stupor, coma, or even seizures. And importantly, they usually lack those Kussmaul respirations or the fruity breath associated with ketones in DKA.
Okay, the neurological signs are a big clue there. Now, it's not just about what these conditions are, but why they happen. There's a really helpful mnemonic, the 8 I's, that clinicians use to remember the common triggers.
Yeah, the 8 I's are a great way to systematically think about what might have precipitated DKA or HHS. It helps ensure you don't miss something obvious.
Let's run through them. What's the first I?
The first, and maybe one of the most common, especially for DKA and known diabetics, is insulin non-adherence, simply missing doses or not taking enough insulin.
Makes sense. Number 2.
Infection, this is a huge one. Pneumonia, urinary tract infections, sepsis, skin infections. Any significant infection ramps up those counter-regulatory stress hormones we talked about, worsening glucose control.
Okay, infection. Third.
Infarction. Thinking mainly about myocardial infarction, a heart attack, or a cerebrovascular accident, a stroke. These major physiological stresses can definitely trigger DKA or HHS.
Stressors like MI or CVA. What's next?
Fourth is inflammation. Things like pancreatitis, cholecystitis, any significant inflammatory process can be a trigger. Pancreatitis is a classic one.
Right, the 5th I.
Iatrogenic. This means caused by medical treatment or medications. Glucocorticoids like prednisone are well-known culprits. Some diuretics like thiazides, atypical antipsychotics, even, interestingly, SGLT2 inhibitors, a newer class of diabetes meds, can sometimes cause DKA, occasionally even with relatively normal blood sugar levels, so-called euglycemic DKA.
That's important to know about the meds. Sixth.
Illicit drugs. Things like cocaine, crack cocaine, other stimulants can precipitate these crises.
Okay, seventh.
Inexperience or ignorance. This sounds a bit harsh, but it really refers to a lack of patient education. Maybe not knowing the sick day rules, how to manage insulin and fluids when ill, or just a poor general understanding of their diabetes management.
Education is key. And the final I.
The eighth I is initial presentation. Sometimes, unfortunately, the first time someone finds out they have diabetes is when they present to the emergency department in DKA or HHS.
Wow. That 8 I's framework really underscores how vital it is to look beyond the immediate metabolic chaos and figure out the underlying trigger for prevention and, comprehensive care.
Absolutely. You have to treat the numbers, but you also have to treat the cause.
So once one of these conditions is recognized, swift and precise intervention is crucial. What's fascinating, as you've hinted, is that while DKA and HHS differ, the core management pillars have some really important common threads, don't they?
They do. While the emphasis might shift slightly, the fundamental approach involves 4 key pillars. Management is really a race against time.
Okay, what's pillar number 1?
Fluid replacement. This is almost always the immediate priority, especially in HHS where dehydration is so profound, but it's critical in DKA too. We need to restore intravascular volume.
How is that done typically?
Usually starts with intravenous, 0.9% normal saline, isotonic saline, often quite rapidly in the first hour, maybe 1 to 1.5 liters, then adjusted based on the patient's hydration status, electrolytes, and urine output. Later fluids might be switched to half normal saline, 0.45%, depending on the corrected sodium level.
And you mentioned something about adding sugar later.
Yes, that's a crucial point.
Yeah.
Once the blood glucose starts to come down, typically to around 11 to 14 millimoles per liter, maybe 200, 250 milligrams per deciliter, we add dextrose, usually 5% dextrose, D5W to the IV fluids.
Why add sugar when you're trying to lower it?
It seems counterintuitive, right? But it's to prevent hypoglycemia or low blood sugar. We still need to continue insulin therapy to shut down ketone production in DKA and fully correct the metabolic state, but we don't want the glucose to plummet too quickly or too low. So adding dextrose allows us to keep the insulin running safely.
Got it. That makes sense. So pillar 2 must be
Insulin therapy. This is administered as a continuous intravenous infusion. The goal is to suppress ketogenesis in DKA and, in both conditions, to gradually lower the blood glucose.
Is there anything you need to check before starting insulin?
Yes, absolutely critical prerequisites. First, you need to have started fluid resuscitation. Don't give insulin to a severely dehydrated patient without fluids first. Second, and this is vital, you must know the serum potassium level and ensure it's at least 3.3 or preferably 3.5 milliequivalents per liter before starting insulin.
Why is the potassium so important here?
Because insulin drives potassium into the cells, out of the bloodstream. If the patient is already low or borderline low on potassium, starting insulin can cause severe, life-threatening hypokalemia.
Okay, so fluids first, check the potassium, and start the insulin drip. What's the usual dose?
A common starting regimen is a continuous infusion of regular insulin at 0.1 units per kilogram per hour. The goal is a gradual, steady decrease in blood glucose, maybe 2.8 to 4.2 millimoles per liter per hour, or 50 to 75 milligrams per deciliter per hour. Too rapid a drop can be dangerous, potentially causing cerebral edema, especially in kids.
All right, slow and steady. This leads perfectly into the third pillar, which you've already highlighted, electrolyte management, especially potassium. What's fascinating here is just how carefully potassium must be managed, isn't it?
It really is one of the trickiest parts. As mentioned, insulin shifts potassium into cells. Also, correction of acidosis itself causes potassium to move into cells. Plus, patients often lose a lot of potassium in the urine during osmotic diuresis before they even get treated. So even if their initial potassium level looks normal or high, their total body potassium is usually depleted.
So you have to anticipate that drop during treatment.
Exactly. That's why serum potassium needs to be monitored very frequently, often every 1 to 2 hours initially. The guidelines are quite specific.
Can you give us the gist?
Sure. If the potassium is less than 3.3 or 3.5, you actually hold the insulin and give potassium replacement first, maybe 20 to 40 milliequivalents per hour, until it's above that threshold.
Okay, hold insulin if K+ is low. What if it's in the normal range?
If potassium is between, say, 3.3 and 5.2, you generally ADD potassium to each liter of maintenance IV fluid, typically 20 to 30 millimoles per liter, aiming for about 10 millimolar infusion rate to prevent it from dropping. You might also consider giving some magnesium sulfate first, maybe 2 grams, as low magnesium can make it harder to correct low potassium.
Interesting point about magnesium, and if potassium starts high.
If it's above 5.2, you do not add potassium initially, but you still monitor it very closely because it will almost certainly fall once insulin and fluids are going.
It's a real balancing act. Okay, fourth pillar.
The fourth and absolutely essential pillar is treatment of the underlying cause. Remember those 8 I's. We need to actively investigate and treat whatever precipitated the DKA or HHS.
So giving antibiotics for infection, cardiac care for an MI.
Precisely. Or addressing medication non-adherence through education and support, managing pancreatitis, whatever the trigger was. If you don't address the underlying cause, the DKA or HHS might not fully resolve, or it's likely to recur. This is crucial for successful resolution and preventing it from happening again.
That makes total sense. It truly highlights the need for constant, meticulous monitoring in the clinic, checking blood glucose frequently, electrolytes, maybe venous blood gases for DKA to track the acidosis, serum osmolality for HHS, using all that data to guide every therapy adjustment. It's an intense hour-by-hour process.
It really is. It's about carefully guiding the patient's physiology back towards balance. And then eventually, once the crisis is resolved, the acidosis is gone, the osmolality is normal, the patient can eat, transitioning them back to their usual subcutaneous insulin regimen.
So what does this all mean for you listening in? We've taken a pretty deep dive into DKA and HHS. We've looked at distinguishing their core mechanisms, identifying those unique diagnostic markers, uncovering the common triggers with the 8 I's, and laying out the vital steps in their management.
Yeah, it's clear it's a complex interplay of hormones, fluids, electrolytes, things that, when they get seriously out of balance, can rapidly become life-threatening.
Absolutely.
And this raises an important question. Understanding these complex conditions isn't just for the emergency clinicians. It's really about recognizing the profound impact of something like insulin on the body and the critical, delicate balance required to maintain health. Knowing these differences, it really empowers you with insights into how the body can go into crisis and the kind of precision that's needed to bring it back from the brink.
So let's leave our listeners with a thought. Considering those 8 I's that can trigger these emergencies, infection, missed insulin, inflammation, stress, and so on, what might be one small proactive step someone could take, maybe in their own life or community, to potentially mitigate the risk of such an event? Or perhaps, how might this knowledge shift your perspective on managing chronic health conditions, not just diabetes, in our increasingly complex health landscape today? Something to mull over.